Glad to know you're still with us, and moving on to our first conversation for today. Tuberculosis, that's TB, is one of the top 10 causes of death worldwide and the leading cause of death from a single infectious agent. Though curable and preventable, in 2019 it accounted for an estimated 1.4 million deaths globally, of which more than 150,000 were Nigerians. According to reports by the World Health Organization, WHO, Nigeria has the highest TB burden in Africa and is one of the 8 highest TB burden countries in the world that accounts for 2/3 of new TB cases globally. A major challenge in the TB response in Nigeria is low TB case detection, as only 1 in 4 people with TB is diagnosed. Well, joining us today for more on these are Dr. Abidin Okikiola, Senior Consultant, ANADAC Group. Thank you for joining us today.
Thank you for having me.
And we also have with us Dr. Olubumi Margaret Ogbodu, Public Health Professional and SDG Advocate. Thanks for joining us today.
Thanks for having me as well.
Well, it's interesting to note that they are both Senior Consultant, ANADAC Group, and Project Lead, USAID, Nigeria Tuberculosis Local Organization Network. Well, welcome to the show today.
Pleasure to be here.
All right, let's start with you, Dr. Abidin. Talking about tuberculosis, what exactly is tuberculosis?
Yes, like you've rightly mentioned that it's an infectious disease. It's interesting to know that tuberculosis is an ancient disease, as ancient as you can imagine. It's actually caused by a bacteria called Mycobacterium tuberculosis. Usually caused, when an individual who has tuberculosis comes in contact with another person, when I say contact, very close contact, and the droplets are released and the other person, inhales, and they eventually, come down with the disease.
All right, so what are the causes?
The cause is the Mycobacterium tuberculosis.
Okay, there are no other causes, there are no other things, maybe, okay, fine.
Okay. He just said, it has to do with someone who is infected, either coughing or breathing, basically the droplets, and then it gets, transmitted. Yeah. While looking at other means of transmission, is that the only way it can be transmitted from one infected person to another?
Basically, that's mostly how it is.
It's an airborne disease, so it is transmitted through the expulsion of droplets, like you mentioned, and from one infected person to another who is not infected. However, there are some factors that might increase an individual's predisposition to coming down with TB. Those we refer to as risk factors for TB. That's if an individual does not have an immune system that is, we say, has a good immune system. It's not able to fight that
bacteria.
The bacteria.
All right.
And so that's basically, but it's spread through the air, it's airborne, and that's why you're able to spread it fast. When somebody coughs, sneezes, or sings, or expels droplets, basically.
You talked about the risk factors. You want to run us through some of them?
Okay.
So now let's calm down. The tuberculosis. We're talking pulmonary tuberculosis here.
Oh, okay.
There are other forms of tuberculosis. In fact, you could have it affecting various parts of the body. In fact, you could affect the gastrointestinal, the digestive system where that you can get through milk, but it's not as common as the one that is of public health importance, which is the one that's pulmonary tuberculosis affecting the lungs. So that is basically what we are talking about. That's why we're
specific.
It's very specific about the mode of transmission.
Okay.
I think he was asking you about the risk factors.
So risk factors, basically, it's a disease of poverty. Anywhere you find squalor, poverty, you find tuberculosis. So poverty, overcrowding, then that's at a systemic level. No, at individual levels now, when an individual has a low immunity, in fact, most of us have been exposed to it. So we have what we call the latent tuberculosis. That is, we've been exposed to it, our body has more or less walled it off. Now, if such an individual later at any point in time has anything that has reduced the immunity. For instance, the person has HIV. In fact, one of the main reasons why TB is making a resurgence now is because of HIV, where there's reduced immunity. You have diabetes. The person is on certain drugs that actually suppress the immunity. Then the person is malnourished. So you find the latent tuberculosis suddenly becoming active tuberculosis.
Okay, before you continue, at this latent stage, if the person gets tested, would the person be positive?
Now, for the latent tuberculosis, the test that we do, there's an advanced test that we do that would pick whether latent or active, but would not be able to separate the two. We call it quantiferon test. Yeah, quantiferon TB test. So it tells you that yes, this person has been exposed to tuberculosis. You really can't tell that it's active or not. So to say that it is active, we now have to do other tests. So typically, when, for instance, you're joining an organization, depending, so some would look out for TB at all. Some would look for active forms of the tuberculosis.
Okay. You talked about tests now, latent and now active. Is there an instance where the way you have some people down with certain diseases but they're asymptomatic because they're not showing symptoms? Can you have that for tuberculosis as well?
You sound like a doctor already.
Yes. Yes. You're so correct.
Okay. So in such an instance, how do you the individual does not even know he or she has is down with tuberculosis. How then do you as a professional now, how do you advocate that such a person should probably go for, in quote, a random test just to ascertain that he or she doesn't have the disease?
Or be sure that he or she has
it, as the case may be.
So typically when patients come in, people do annuals. This is something I encourage people to do as often as possible. So even organizations, particularly private organizations, to actually do annuals for screening for their workers. So an individual comes into a clinic, usually does not have any symptom. As simple as a chest X-ray might actually help guide us. And we tend to ask a few basic questions. So, are you coughing? Are you losing weight? Do you have chest pain? Have you come in contact with anybody who is coughing? Now, this cough, in the books, it says 2 weeks or more. But we found situations where an individual is coughing for even a day or two. It's what the person tells you that you work with. So the person tells, I've been coughing for 2 days. Definition of cough is again individualized.
Exactly.
Yes. So somebody would say, I'm coughing only when it's really, really affecting me. So some people just cough, casually, and they don't say it as anything important. So any form of cough, we want to go after it. Now, so are you producing anything? No, if you are producing, we have to test that as well. There are tests that we do. In fact, right now we do what we call the Gene Expert test. Yes.
When you say are they producing anything, you're talking about the phlegm, the texture of the phlegm, and the color as well.
Precisely.
Okay, but
sometimes it's stained with blood.
Blood, yes.
That's hemoptysis, where you have the sputum stained with blood. But just like you said, these days we find a departure from the traditional symptoms, which infected persons present with. And that's why even for cough as little as 2-3 days, we still query and still recommend such people for further screening. So that sure, particularly if you are also familiar with maybe their background, like you said, poverty, and most likely they'll be malnourished, they're not feeding well,
underlying health conditions,
and probably also living in crowded environments. So those are.
Well, speaking of the departure you talked about, can you run us through, what used to be or the regular and what you're beginning to see in terms of signs and symptoms?
So the departures. So, like I said in the books, it says 2 weeks or more. That's what we call chronic cough. Unlike what most people would think that the word chronic means severity. No,
Okay.
it's about length of time. So 2 weeks or more is regarded as chronic. So what we see now is individuals coming with 1 day, 2 days, and we find people who are not, symptomatic. They show no signs, no symptoms. Out of possibly, out of the blue, we just do some screening, like a chest X-ray. Lo and behold, these days that people are migrating, using our local parlance, Japa, they have to go through a lot of screening. So we've had to see a lot of cases that have been picked. These are people who are asymptomatic. A lot of people who are, for instance, going to migrate to the UK so they're expected to actually be screened for tuberculosis. And what they usually do is a chest X-ray. So we found situations where people have been picked.
Okay, just before we delve into what the organization is doing to address all of these, I would like to get your thoughts. You said earlier that it's there's a departure. Now, in terms of the signs and symptoms, can't it be confused for probably a regular bout of influenza? And I'm saying that because you have a 2-3 days cough and you're bringing out phlegm. It's probably thickish and has different colors, maybe yellowish or greenish. You just feel it's an infection, and you do not even consider tuberculosis as one of the signs.
Doesn't come to mind.
Exactly. I just think maybe I got drenched by the rain and it's just a bout of influenza.
That's why this further screening is key. But the traditional symptoms that a TB patient would present, traditional, fever, chills, which you will find with so many other conditions. Then there's what we call the night sweats. And this night sweat, you find an individual in a space that is properly has a functioning air conditioning system, but the individual is sweating, and it occurs at night. It's not as if there is power outage, so the room is well ventilated, but the individual is still sweating profusely. It's night sweats. We have fever and chills, headache, which is the same regular, hemoptysis, that's cough stained with blood, the phlegm stained with blood. But now we're having a departure from that. So sometimes the cough, you don't have the blood stain, perhaps because the length of time also, you don't have up to, sometimes it's less than a week. And so instead of waiting for, because before people start coughing up blood. Already, there's already some, they're already having some issues with their with the circulatory system as well. As that's why they have to cough up blood. So it's I would say this day the departure even helps faster diagnosis.
Still talking about this departure, what exactly is responsible for it? All of a sudden things are changing, and the length is getting shorter. I want to believe there's something responsible. Is it the weather? Is it what exactly is responsible for that?
So when we say the length is shortening, it's a subjective observation. It is what the patient tells you that you work with. For different people have different definitions of what they consider a significant cough. An individual, they just try to clear the throat and doesn't see it as cough. In fact, some people are coughing, but because it doesn't affect their sleep, it doesn't affect their their daily routine, they don't see it as anything important. They now report to you as cough when that begins to come in. So they will tell you, I've just been coughing for the past 1 week. But meanwhile, that cough has been there longer. And the question you were asking earlier, where you say you could be confused for
about influenza.
So again, it makes me doubt if you tell me that
doesn't have some background in there.
I see maintain that probably you went to medical school. So you find that some of all these other conditions would usually present shorter. For instance, COVID. COVID, you come in contact, the person would cough with COVID as well. But what we call incubation period, you come in contact and you begin to manifest. For tuberculosis, it's a lot longer. Sometimes you may not even, throughout life, it's probably as autopsy that we find out that, hey, this person actually had during the lifetime. But with COVID, within a week, the person comes down with symptoms. And the symptoms are usually, more magnified. Within a very short time. Unlike tuberculosis, it's insidious, it's gradual, it begins to creep in.
In other words, when the blood begins to manifest in the phlegm, that's more like an advanced stage.
Yeah, precisely. So what that is saying is the disease is actually more or less eating into the lung tissue and now exposing blood vessels. So when the individual coughs, it coughs up the blood.
Okay.
Again, this could be confused with vomiting blood. Some would come and say, I am vomiting blood.
Maybe they brushed.
Exactly.
All right. So apart from this, are there other complications really?
When we say complications, apart from say the symptoms that the individual presents with, it's a debilitating disease.
Okay.
Thankfully, it is curable. So you could have it spread elsewhere.
Okay.
To the bones, to the brain, to the kidneys, even to the skin, to the eyes.
Those are the non-pulmonary.
Yeah, those are the non-pulmonary.
TB can be pulmonary or non-pulmonary. So those other sites are non-pulmonary.
The resurgence that we are seeing is actually linked directly with HIV.
Okay.
Yeah, so you find somebody who is immunocompromised, they usually do not die of the HIV itself. It is what we call them opportunistic diseases. So tuberculosis ranks very high.
Okay. All right. Looking at the prevalence, looking at the prevalence. Okay, let's look at age now. What's the age distribution really for tuberculosis? Is it that the children come down with it? At what age is it more prevalent?
Yeah, you would like to take that?
Yes. These days we are having an increase in the incidence for children actually in childhood TB, and that's we can also say is due to the poor vaccine coverage, the BCG vaccine that is given at birth. So you can have TB in children and also in adults. Yes, but more prevalent, yes, in adults today. But we have data to show that there's a rise in the incidence of childhood TB.
So for these children, is it that they had the BCG vaccine and then along the line they still came down with tuberculosis, or somehow they missed that chance?
No, well, not necessarily. Now, the BCG is not 100% protective.
Okay.
When you take the BCG, what that means is when you catch tuberculosis, you are unlikely to have a very severe form of it.
Okay.
Brings it down.
So more or less, yes, more or less.
Makes it milder.
Yes, makes it milder. The impact unlike somebody who did not take at all. The person who did not take is at a higher risk of coming down with it. So it is not 100%. Protective.
All right. Yeah. I guess that's in the way of that talks about prevention. So for adults now, apart from the BCG, are there other ways to prevent one from coming down with tuberculosis?
Yeah.
Go ahead. I was just going to say that BCG vaccine confers no advantage for the adults.
No,
it's only for children.
It's for children.
Yes.
Okay.
So, go ahead.
Quickly, before you answer that, I was about asking, oftentimes with medical practitioners, they give like an age range of those who are most vulnerable and all of that. Talking about tuberculosis as well, are we looking at an age range, maybe 18 to 40, in terms of those who are more vulnerable?
So we have, those who are, the under 5s.
Okay.
So that's why we insist on the vaccines be taken. Then now we're finding it amongst adults, young adults, to be precise. Yeah, in the young adult, particularly again, it is higher amongst males than female.
Wow.
That even those that come down with complication tend to be the males than female. We know our health-seeking behavior. Women tend to are more prone to present to the hospital faster than a man would. So you find complications arising, amongst men. So talking about prevention, so one of the preventions that we're talking about now is what we've mentioned about
BCG.
the vaccines, the BCG vaccines.
Young age.
Yes, at a very young age. I mean, once a child is born, within
a few days.
Yes.
Yeah, 2-3 days.
Yes, the person takes it. Other things would be avoid overcrowding, proper ventilation. you know, when we talk of cross ventilation, we know that most of the homes that we have around,
this part of the
world, so they are not properly ventilated. Once you have good ventilation, it's unlikely that it will spread. So what this thing wants, it wants to be in an enclosure. Then the other thing would be, you know, proper nutrition. So anywhere you find malnutrition, you find TB.
Okay. You're talking about nutrition. I hear a lot about people saying that, you know, well, Nigerians eat, but the question is how nutritious are these meals? Balanced. So what are the things we should start looking at if we want to start taking nutritious meals? I mean, it's one thing to eat, it's another thing for it to be nutritious.
You want to run us through that?
Well, balanced diet is having a mix of the necessary
food
classes of food. And of course we know that also in this part of the world we have most of our diets to be heavy in carbohydrates. So people need to take deliberate attempts, they need to make deliberate efforts, you know, to have balanced meals, have a lot of vegetables, have a good mix of proteins, vegetables, carbohydrates, not just well, this is what is available. We just, even with incomes that are not so high, you could actually have balanced diet. But reliance on making that extra effort, you know, to ensure that your meal has a good mix of these food classes, not too much of carbohydrates, and then have your protein, have your vegetables, so that you're sure that and vegetables, yes, prices of things have gone up. But the grains are affordable, exactly.
All right. Well, very quickly, I remember, during the course of the conversation, we talked about late presentation, how that some persons do not present early. And I believe that's a problem, really, when you do not present early, that would increase the mortality rate. So talk to us, what is ANADAC doing about this? You know, getting the information out there so people know that, okay, when you see the sign, you need to go to the hospital. Don't take to the streets. Don't take care of yourself. See a professional.
Okay. Thank you. So for us at ANADAC, what we're doing basically is to increase awareness for TB in the private sector. Not many people are aware that TB is still a challenge, that is still with us. And the fact that Nigeria has the highest burden, when we talk to people, people are like, oh, really? Really? So we advise that employers of labor also do not stigmatize staff members who have become infected with tuberculosis. Why? Because TB is
at risk.
They are at risk, but TB is preventable, is treatable. And then when you stigmatize the individual, you stigmatize the family members who also give care. Then it prevents those other people who also become infected to come to speak up. They won't, and when they don't speak up, they end up infecting others. Once an individual is perhaps suspected to have or to have had cough for some time, there are health facilities that they could be referred to. And treatment for TB is free at government facilities. It's actually free, but not many people know that it is free. So part of what we are doing is to sensitize the private sector to say TB services are free at government hospitals. Walk in there, you'll be screened, and then you'll be placed on the drugs at no cost to you. Of course, yes, you need to get yourself to the facility, and then, but the fact that you can have access to the drugs, and for employers, they need not worry, because when these patients are treated, then the physician who attends to them is able to give a medical certificate of fitness that they are free to return to work. And when an individual is infected with TB and is confirmed to actually be infected, once the individual has been placed on the drug, within the first two weeks, the bacteria, we say, becomes sterile. And so that individual can no longer infect others and can actually return to work. So all the employer needs to do is just to have maybe some modifications or adjustments made to their work schedule, so that they have time to also go take their medications and then get back to work.
That's it.
Okay. Still talking about ANADAC group, are you also looking at the resistant TB that is on the rise now? What's being done, you know, to address it?
Okay, Dr. Kelly.
So it all forms, you know, in the same you know, purview. So first things first, let's even, you know, the private sector know
Why
and in the
private
public.
sector? I think there is this emphasis on the private sector. Why?
Now, because there's a disconnect.
Okay.
Now, everything has been thrown on government.
Yeah.
That it has to be led by
the
government.
government.
So the private sector is actually left behind. And this has created a huge gap. Because people who are in the private sector feel no responsibility to their employers. So their employees. As far as the health issues are concerned. You know, some of the things that we see in the hospitals would be that an individual comes down with tuberculosis, they lay them off. That's straight up. If you're doing screenings, you find an individual who has tuberculosis, they are not employed. So the important thing why ANADAC is now interested is, look, we're now telling the private sector that yes,
they have a role
to play in the prevention, the spread of tuberculosis. Now, if they are not well treated, then you now begin to have this resistance. An individual, the instance you mentioned, the person doesn't want to come forward. The person manages to come forward, is being treated, and now stigmatized. He tends to want to stop treatment. So that guy is going to evolve into developing resistance, such that by the time you bring the person back, the drugs don't work anymore. You now have to use more expensive drugs that are at least 3-4 times more expensive than which are not readily available, and treatment is a lot longer.
Okay. Talking about that, the question then would be, we know with medical ailments there's always the possibility of relapse. For someone who has undergone tuberculosis treatment and is certified, medically fit and whole by the doctors, is there possibility of a relapse?
Absolutely.
Once the person is cured, he's cured.
Okay.
So as long as the person uses the medications as
completely
prescribed.
okay.
Yes.
So treatment is usually for tuberculosis, the uncomplicated one, 6 months.
Okay.
So we give a combination of drugs for the first 2 months, which we call the intensive phase. Then the next 4 months, which we call the continuation phase. The person takes it, and in between, we do tests to check the efficacy of the drug. Is it working or is it not working? So at 6 months, once we clear that person, it does not mean that this individual cannot come down with tuberculosis again. If exposed. I've had a lot of people that we've treated multiple times. So in that kind of individual, I start treating you. Suddenly I find out in between that something is off. I begin to think, could this person have a resistant strain? Is it that the drug failed? And unfortunately, one of the drivers of the failure of the drugs right now is because these drugs are available in the market. So people just use them indiscriminately.
Okay.
Instead of getting them from the accredited government facilities that they ought to take it. And I would like to add on the why the private sector, there's a track record of success recorded from private sector participation in public health interventions in Nigeria. With polio, with malaria. The private sector played a critical role, in ending those diseases. So it's that's why we're leveraging on the success of such public health interventions of the past to say, okay, it worked with the private sector. So much is in the public space about TB. At least maybe say government is doing their bit, but they can't do it alone. And then private sector, we know, for instance, in Lagos, Lagos State is a private sector driven state. And so if the private sector is not even aware that TB is a problem, how are they also going to show support for their employees to get treatment as at when due from those facilities?
Earlier you talked about government hospitals offering free treatment. I wanted to take you up on that because we've had complaints over time of how some of these government facilities do not have the necessary equipment or even personnel as a result of the brain drain in that sector. So that individuals who will tell you, to even see a doctor is like a Herculean task. It takes days before they can really meet with a doctor and have a proper discussion, diagnosis test, and all of that. There have been reports of no bed space and all of that. We know all these realities and challenges. So the question will be, for those individuals who, as a result of our discussion, begin to think like, okay, probably I have signs and symptoms of tuberculosis, but as a result of the uniqueness, let me put it that way, of public government facilities, they may not get treatment as quickly as they want. If they decide to go through, private hospitals, how affordable are these treatments?
So let me come in here. So
okay.
I give a first-hand instance. Lagos State government has actually tried to invest a lot. Working with partners.
Yeah.
So what, for instance, a hospital like Bagada General Hospital, patients come in, they have what we call cough officers. Now these people just go around random. They're asking everybody who is present, irrespective of what you came with. Are you coughing?
Okay.
Do you have this? Do you have that? Once you have that, they remove you from the crowd.
Okay.
And they give you, cups to go and cough into, and that test is particularly free.
Okay.
The only one possibly you pay for probably is the chest X-ray, and it's usually subsidized. Yeah, very subsidized compared to what you get outside. So once that individual is positive, the treatment is straightforward. In fact, you don't even go through the process. We just fast track you straight to what we call the DOTS clinic.
Oh.
That's the directly observed treatment, therapy short course. We'll send you straight to that clinic where you access your drugs for free. 6 months.
Okay, that's quite impressive.
Yeah, and
apart from Lagos, is that obtainable in other places? Because some of us must have probably seen these things. But then, apart from Lagos, are these things obtainable in other places? You mentioned Bagada. What about maybe some rural areas or some places that are, in the slums in Lagos? Are they also, available just the way you painted it?
So, as far as Lagos State is concerned, they've designed what we call the spoke and wheel, referral system. Okay. So you pick, if for instance I pick the person at Bagada and this person says I live at
Alimasho, is that far? I don't know.
Which is far, precisely. Yeah, which is far. Next thing I'll do is there's a directory that is available.
So
I'll look for the closest facility to that person. Okay. It doesn't necessarily have to be another general hospital. It could just be
a primary health
care center. Okay. I call that person there and say, look, this person I am sending over. And we'll track that person's referral just to make sure that this person does not is not lost to follow up and does not miss treatment.
Okay. Yeah. You're about saying something there.
Yes, I was going to add that we also have some private health facilities that are also accredited to provide TB services for free. Because under this scheme.
Okay.
Why? Because we've also had some feedback from the field where people say, they don't want to go to government hospitals. They don't want to go to a primary health care center, and so there are some private health facilities that are accredited to also do this, because TB shouldn't be treated outside the government framework. There's a framework that guides the treatment, and because TB is a notifiable disease, so as cases are presented, there ought to be record. We have issues with record keeping. So that's basically what it is. And I can certainly tell you that in Lagos, Ogun, Oyo, and Osun states,
Southwest, basically,
yes, there are facilities that you could get these services for free. Yes.
So what about the other states? You can't say for sure.
Well, the TB service, ideally, TB should be is government baby.
Okay.
So it's a disease that should be, every state's government should have provision for taking care of the citizens within because the project that we are working on is in the Southwest.
Okay.
And so these facilities, and in these states, we can tell you that the facilities are making these services available.
But what would you say has been the response so far, really, since this partnership with government? I mean, your project.
The project, well, yes, there's increased awareness.
Okay.
Because this project we started 2 years ago, and driven by USAID, we've had people become more aware that TB is an issue. And part of what we're also doing, we're also offering training. We offer training to occupational physicians and also health and safety professionals in private sector. so that we walk them through what are the signs and symptoms, the types, what to look out for. If the employee also comes down with any of these symptoms, where to refer them to, we share with them a comprehensive list of facilities where the individuals could be referred to, all their relatives. Just like Dr. Abidin mentioned, we try to also get them to use health facilities that are closest to them. So logistics does not become an issue. So the response has been encouraging, but of course it could be better. And that's why we're also leveraging on different platforms to get word out that TB is preventable, it is treatable. We should not stigmatize people. And actually the treatment is also free. So why not? So that we can have a healthier society.
Yes. Okay,
Right.
your final words?
TB is treatable, it is curable. Do away with the stigma.
Thank you very much.
All right, we'll take a break now. Well, we'll come back. We have more conversations for you. But of course, this one has come to an end. Thank you.